And then Sharon, I don't know if you want to tag team this or what, but I kind of put
Sure.
it together. Yeah,
I think if you just want to start and I can add in if I need, Abby,
that
or
sounds that sounds great. Yeah. So this is the definition that the EC has provided for ductal dependent pulmonary blood flow. It's a heterogeneous group of lesions with a common feature of requiring a patent ductus arteriosus after birth to provide adequate blood flow to the lungs. So there's, a couple different populations of ductal dependent pulmonary blood flow. And those are patients with a single ventricle. So for instance, the major one that we think of is tricuspid atresia. So these patients will undergo some sort of initial palliation to maintain that the blood flow to the lungs. And then at around, depending on your center, 3 to 9 months, they'll undergo a second stage, which is the Glen or something similar, Hemi-Fontan. And then for our two ventricle patients, these are usually our TETs. And then, others who maybe have pulmonary atresia or stenosis. And then these patients will undergo their initial palliation. And then once again, at around 3 to 9 months, depending on your center, they'll undergo their complete surgical repair or their TET repair.
kind of an easy way to see if it's ductal dependent. The kids will, by definition, need to be on prostaglandins, because if they're not on prostans, the duct will close. So if they're not on prostaglandins, they're probably not ductal dependent. The other thing is, try and think in your head, which way is the blood flowing through the duct? Is it going out, like from the ventricle through the pulmonary artery and out to the aorta, which is hypoplastic left heart? Those are not the kids we want. That's systemic dependent. But if it's ductal dependent pulmonary blood flow, the blood's coming from the aorta through the duct into the lungs, because that's the only way blood can get to the lungs. Or if they have like a small pulmonary valve or some stenosis, that not enough flow can get up into the lungs from the right ventricle. So are they on prostaglandins, and which way is the blood going through the duct?
Yep. And then, as Sharon said, we usually maintain this. We want to keep that duct open. And the main way to do that right off the bat is with prostaglandins. And of course, you can't, most folks wouldn't recommend doing that forever. So we have these different palliative options, right? So to list off the cath options that you might see, one of them would be putting a stent in that duct, so a ductus arteriosus stent. An RVOT stent, basically a stent within this right ventricular outflow tract to make sure that remains patent. Or they could undergo a balloon pulmonary valvuloplasty, which is where they'll put a balloon in and inflate it. Anything to add to those, Sharon?
No, and I love the graphics.
Thanks. So our surgical palliative options. So one of the main ones that we see commonly is this systemic to pulmonary shunt or a BTT shunt. Or you might find, or the other population that we're really looking at is some sort of RVOT intervention, but without a VSD closure. So like some sort of patch augmentation of the right ventricular outflow tract. And then lastly, and sorry if this animation is not the greatest, but we'll have our primary repair patients. These are patients who will undergo, for whatever reason at your center, they elected to undergo primary repair right off the bat. So within the first 30 days of lives, these are the patients we're looking at. These patients, the full centers will be entering these. Limited sites don't have to worry about these patients, but just as a quick review, they'll ligate the ductus, they'll perform patch augmentation of the RVOT, and then they'll also close the VSD. And I see Jade has a question.
Hi, can you hear me? I've had any audio issues. Okay. For the other slide with the two palliations for surgery, so is central shunt technically not included in that group? Or
Oh, like an RVPA conduit or?
No,
sure, you're getting more technical than I know, but
Yeah,
No,
Sharon can
it's-
answer.
yeah, a central shunt would be kind of along the same lines as a BTT shunt.
okay, I just wanted to make sure. Okay.
It's just
Okay.
instead of coming off of the carotid, it'll come
Mhm.
off like the aorta. It's centrally, but it's
Right.
still that kind of a surgical tube linking the aorta to the systemic blood flow to the pulmonary flow. There'll be some kind of tube there. And some
Okay.
kids need like extra blood flow, like the stent isn't enough or something else isn't enough, and they'll like add a central shunt, or they'll figure that's like a better source of blood flow. They need a little more. But a central shunt would also be a palliative surgical option.
Okay. Thank you.
All right. That's all I have about the kind of patients and procedures we're looking for this for the CCRC registry. Now, please keep in mind this might, like I said, the type of patients that you're entering might vary depending on whether you're a limited site or a full site. So any limited site coordinators, the only two that you really have to worry about are your PDA stents and your shunts, your BTT shunts, or your, as I know, your central shunts, your systemic to pulmonary shunts.
Abby, that was a great overview, and I really like highlighting the difference because I know I've had some questions come up about the difference, like what do you call palliation? What's the difference between palliation / primary repair on surgery? And basically, at the end of the primary repair, you're going to be left with goods like two ventricles and a working RV and a working LV, and going like normal, almost quote unquote normal circulation at the end of a primary repair. Palliative is going to be something that's going to make the kid last until they grow and they can do the next stage. Does that make sense? Like primary is going to be like, it's a good fix and you should be okay.
So palliation is just temporarily.
Or a palliation is something that it's not going to give you, like our kids with single ventricles, it's not going to totally give them a normal, quote unquote, normal heart at the end of the day. They're going to have palliative things because it's not a fix. It's something that lets them grow and lets them live, but it's not necessarily like giving you back what a typical heart would look like. So palliative will be the shunts that either they're two ventricle or single ventricle or stent until they can grow a little bit and either get a complete repair or get a Glenn or a Fontan. But if they go down the Glenn Fontan route, then those are always considered kind of palliative surgeries because at the end of the day, you have a heart that's not quite typical.
All right. Any other questions about type of patients we're looking for? Any questions in general?